presentation is going to be divided more or less in 3 segments. First, I'll talk about the evidence for MDFT and implementation history. Then I'll give you the details of the intervention as much as we can in this short period, but enough, I hope, that you'll get a flavor of the intervention and, as Elizabeth said, can learn some methods and interventions that you can use in your practice for those of you who are clinicians. And finally, I'll talk about implementation and training. So what is MDFT? That's the big question here, why many of you are here. And we asked folks involved in MDFT to write a few words that would describe what MDFT means to them. And this is what you have here. And so you can see parents, emotional, healing, adolescence, effective, flexibility, planning, challenging, supporting, together. That gives you a beginning sense of it. Who do we serve? People are always interested in this. Well, families with at least one child between the ages of 9 and 26. There's got to be at least one parent, guardian, or parental figure, defined very widely, who's able to participate in the treatment program. The youth or child doesn't require immediate hospitalization or stabilization. Of course, we can serve the child after stabilization, and there are no psychotic features or disorders unless temporary. Now, many MDFT, those are broad eligibility guidelines. Many MDFT programs limit the eligibility according to the nature of their program and their agency. So, for example, many agencies don't see youth over the age of 18, and that's fine. These are the broad, general eligibility requirements. Now, what is it? In the most general terms, it's an integrated family-centered treatment that has very strong outcomes in 10 randomized clinical trials conducted both in the United States and Europe by the model developer as well as independent researchers. And all this is important because this tells us that it's a very strong evidence-based treatment. What does it do? How does it work? Well, it promotes behavioral change in youth by changing the hearts and minds of the adolescent, by changing how parents influence their teens, by changing how the family, teens and parents together, talk about conflict and solve problems and how they love and support one another. The ultimate goal is to reduce or eliminate substance abuse, mental health symptoms, violence, criminal behaviors, and sexual health risk in the teens, and to increase school attendance, grades, positive peer affiliation, and pro-social functioning. And so I have this slide here because I always want to emphasize, although we're changing the family and improving parenting practices and improving the relationship among youth and parents, that's not enough. That's kind of the mini goal onto the ultimate goal of changing behavior. So if we change the family and everybody gets along better and they talk more, but the youth has not changed the problem behaviors, then it's not a success for us. The ultimate outcome is the behavior change in the child, so he or she can be on a healthy and safe developmental trajectory. And what we have found over the many years and numerous studies is that it works, and it frequently works better than alternative treatments such as individual cognitive behavior therapy, various group therapies, and even residential treatment. And what does it, specifically, how does it work? Consistent decreases in substance use, crime and delinquency, violence and aggression, anxiety and depression, out-of-home placement, sexual health risk, and then, of course, an increase in the positive behaviors such as school attendance, academic grades, family functioning, pro-social functioning, effective parenting practices, and positive peer affiliation. Now, it's been recognized by many governmental, non-governmental, academic organizations throughout the world, and I'm just going to click through them. you can look at our website and get more detail, including here in Florida, the Department of Juvenile Justice, but Finland, the Netherlands, Switzerland, it's pretty impressive. I'm going to play a video now, and I'll play videos throughout this, short videos, to give you a sense of MDFT, and you don't have to just listen to me. And this is Peter Panzarella. He was the former director of substance abuse treatment in the Connecticut Department of Children and Families, and now he's a SAMHSA coach, and I'm going to let you hear from him. Oops.
Gail, I apologize for the technical glitch. I can get this going again. Just a moment.
Okay, thank you.
You're welcome.
They were getting fantastic results compared to other treatment models, especially around engagement.
Now let's look. Great. Now let's look at in more detail, a little more detail about some of these outcomes. Great. Okay. Sorry about that. Now let's look at in a little more detail some of these outcomes. So substance abuse, many of you are especially interested in that. And you can see by the graph, the purple is MDFT, that the outcomes are magnificent in substance abuse. The Philadelphia study, in particular, we highlight here the reduction in drug use problem behavior, MDFT, compared to individual CBT, and also in hard drug use, great decline. And also what you'll see when I go through these slides, there's a little section of MDFT in the community. So there's studies and then there's community implementation, which also shows tremendous reduction. A program in Pittsburgh, California, for example, had a 69% reduction in hard drug use. And we'll just go through these really quickly. Arrest and delinquency, also reduction in serious crimes in a Miami juvenile drug court study, and then in another study in Florida, the 1 year after completing treatment, MDFT youth had a 23% arrest rate compared to 44% among group therapy. And we find the same pattern of results with all the outcomes: mental health, school performance, including grades, which is pretty amazing, as well as attendance, home stability, preventing out-of-home placement. A day treatment study done in Miami found that prior to the implementation of MDFT, there was a 37% discharge to a residential placement, and then after the implementation of MDFT, only 3%. Let me see, 1 second. Okay. Now, there are many studies in MDFT, which I've briefly summarized, but also there's the implementation. And the implementation of MDFT out of the academia and into the real world really began in 2001 in the state of Connecticut with 5 agencies. And those 5 programs are still running today, and many of them have expanded. And there are now 21 MDFT programs in the state of Connecticut, including in-home programs and residential MDFT. Now, MDFT is in 8 countries, including the United States, and in 15 states. Over the years, we've learned what are the keys to successful implementation of MDFT. And this is not just true for MDFT, but this is true for all evidence-based treatments, implementing them in ongoing programs. And among the top factors appear to be excellent management at the agency level, the agency having a culture of excellence, a system of accountability, an agency that fully embraces its mission to help youth and families. That's the #1 priority. An agency that spends considerable time and effort in selecting and retaining staff. Clinical staff are important and valued by the agency. An agency that selects excellent staff for its MDFT program, and the procedures in place or willing to put in place that support and retain the staff and the sustainability of an evidence-based program. Now, again, I'm going to play a video here, and Elizabeth, maybe you should do that.
I'll be happy to.
I'm going to play a video here. This is from Catherine Cordo-Mergen, and she is an MDFT therapist, supervisor, and trainer in Connecticut, and talks about the impact of MDFT in her agency. Okay, let's play it.
I don't know. I think it's just, I have real passion for this. I've been involved in it. Started 10 years ago, and I've seen fabulous results in staff in terms of their growth and in the results for families. A lot of the therapists that we work with are young. Some of them, this is their first job. They're right out of school. So there's growth that happens on a number of levels. Clinical skills, professional growth, engagement skills, family work, all of those things. So when I see therapists really start to notice that in themselves and feel that and get stimulated by their own growth, I think that's fabulous. And I think the other thing is those families get better, and the relationships between teenagers and their parents gets enhanced. That's the best. I think for me, the big thing is that it's more planful, and the supervision and the training that goes with it is very intense, so that the skills that therapists get when they provide this modality of treatment are top-notch skills. The agency I work with, we've had MDFT since the first place came to Connecticut 8 years ago, and the outcomes for the families and the cases have been great. Again, seeing, adolescents be able to find their voice and communicate to parents being able to listen through some of the struggles, which we know, just given that developmental period, that's a hard time. I think that's valid. I think the program in the, I'm talking about, because we have an MDFT program in the village, but then we also have the training component, so it's two things. I think the actual program in the village, in terms of services in the village, it makes it better because we offer something specifically for adolescents, and that's a population that's hard to find services, and not just anything, but really the Cadillac of services for adolescents with substance abuse problems. And working in an urban environment, there are a lot of those teams that need that kind of work. So, also, I think the staff that work in that program inspire other staff in the agency. I know that other staff will come to them and ask them things about substance abuse, about just adolescent issues, about family work. So the staff in that program are kind of seen as experts in the
Okay, I'm transferring control back over to you.
Okay.
There you go.
So in MDFT, I hope that gives you a little flavor. What I really like about what Catherine says, especially, is how she said the MDFT program enhances their whole agency for the better, and that's just wonderful.